LVAD is a new procedure. Jim, you want to talk a little bit about
so this policy, we're encountering more and more patients with left ventricular assist devices. It's a long policy. It's about almost 4 pages, and it's really there this time around to give a lot of education, because it's something that I think a lot of our healthcare providers, EMS providers, as well as a lot of physicians are not terribly familiar with and don't encounter a lot of these patients, but we're going to be encountering more and more of them in the healthcare system, and this is going to involve EMS. The biggest thing, the most important, I think, take-home points when you're dealing with an LVAD patient is, one, use the family or as a resource. If their family members are there, they're probably going to know much more about the device than you do. And these patients also should have a VAD coordinator. So there is a phone number to call. It's usually listed on the device. The family member should have it. The patient should also have a card to call that person for assistance with dealing with these patients. And they're usually, it's usually a nurse. They're usually very helpful in dealing with these patients. The next question comes up: what do we do with a patient with a left ventricular assist device who's in cardiac arrest? A lot of the manufacturers will say absolutely no CPR under any circumstances, and the thought process is you can dislodge the device from the left ventricle, cause excessive bleeding, obviously a bad event should it occur. For the most part, CPR should not be done in these patients. If you're in a unique situation where you've confirmed that the pump is not working, if you listen over the pump for sounds, you're not hearing anything, the patient is unconscious, unresponsive, you can't get up a pulse, blood pressure, pulse X reading, capnography is there, and the patient does not have a valid DNR in place, you may need to resuscitate in those circumstances and definitely try to get the VAD coordinator, medical control, for guidance. But for the most part, these patients should not be resuscitated unless we can confirm the pump has truly failed, or they have obvious signs of death, such as lividity or rigor mortis.
When transporting an LVAD patient, please make sure they usually have a backpack or whatever of supplies with extra batteries and cables, rechargers, things like that. Please make sure you bring that with you when you transport the patient. And ideally, if it's possible, transport the patient to the facility that placed the LVAD. Certain circumstances, certainly that's not always going to be possible, but that would really be the ideal situation.
All right. The next policy we have is our patient status determinant. This before was called patient status determinant and transport decision. We moved the transport decision out into a separate protocol, and we've added, again, the STEMI and stroke bullets under our status 2 patients.
And another sort of change, or in addition to this, basically the destination hospital and mode of transport should really be determined by the pre-hospital provider taking care of the patient with the highest level of medical training. It should typically not be done by fire, police, or bystanders. So that pre-hospital provider with the highest level of care should really determine mode of transport, whether it be ground, air medical, licensed sirens, non-licensed sirens. They should be making those determinations.
Please, while we're talking about transport decisions, please also be cautious with the use of lights and sirens. If your patient is not critical, doesn't have a life-threatening injury, lights and sirens probably not indicated. It really puts you at greater risk for having an accident. The patient likewise is potentially injured during that transport, as is the public at large as you're going lights and sirens. So unless that time is truly, truly critical, please minimize the use of lights and sirens.
Okay. Pediatric transports. There's no change in this protocol. On the second page, on item 4, it describes how to secure a child onto a backboard or onto a cot, and it says in a manner to prevent ramping or sliding, and a front or rear end crash. And we just provided a couple of photographs in there to help with the description on how to secure them. Police policies are new policy. When we were looking at the behavioral protocol, And we had decided to move the restraints out separately, and then we talked about, you know, combative patients and putting patients into protective custody, and we were discussing tasers and pepper spray, and we thought, well, maybe we should have something just separate for those patients that the police are involved in. And so we've come up with this new policy. At first, it describes the difference between protective custody and police custody. And protective custody is really when the person is taken because they're a threat to the safety of themselves or to the public, whereas under police custody, it's somebody who's under arrest for, you know, committing some sort of criminal act. So we've separated those out. We've given you the laws that pertain to the protective custody. We've put a bullet in there that speaks about patients that are in handcuffs. And ideally, in the most perfect world, the police officers should be in the back of the ambulance with the patients if they're handcuffed. We know that on occasions in some of those more rural towns that it's not always possible, so if the police officer cannot be in the back of the ambulance, they have to be following directly behind the ambulance. And then anyone who's been tased or pepper spray or excited delirium, if any of those are involved, we've given the links to those procedures.
I think another important point in this policy, if there's an issue where you have a patient, I guess an example would be motor vehicle crash, obvious trauma, you believe the patient is intoxicated, maybe they're getting arrested for DWI, but you're medically concerned about the patient, you'd like law enforcement to place them in protective custody, the patient might be refusing to be transported to the hospital. If you think that patient's at risk and there's a disagreement between police and EMS, two things should be done is request the law enforcement personnel to possibly get one of their supervising officers involved, and also contact medical control for guidance. Try to let them sort it out on that level if there is a disagreement between the police not wanting to put somebody in protective custody and you thinking there's a medical need to do so.
Okay.
So refusal of care is next.
Mm-hmm.
Correct.
This protocol's been changed a little bit. One of the things we did is define what competence, in order to refuse care, a patient must have competence, capacity, and must have an informed refusal. The other thing we did in this protocol is define what is what we consider maybe some examples of high-risk refusals. There are patients who can make bad choices and refuse care, and we think they need medical care, who still might have the capacity to refuse, but we wanted to kind of put a list in there of stuff that should sort of heighten EMS's evaluation of these patients, that they're kind of at a higher risk if they refuse. If you need to get medical control involved, sometimes it'll help to have a physician talk to that patient. Sometimes it'll help to even just get that medical control physician's name on your documentation to add another layer of protection as well, should something go wrong. So the examples of high-risk refusals we put in here, they include, but they're not limited to, if you have treated resolved hypoglycemia, some of those patients can be high risk, particularly if they're on oral hypoglycemic medications. Some of those medications can cause recurrent hypoglycemia. Also, if there's a medical cause for their hypoglycemia, such as they've done everything they should be doing, took their medications they ate as they should, they have hypoglycemia. Sometimes we worry about, could it be due to a cardiac cause? Maybe they had a myocardial infarction, maybe they have infection going on, something like that. If a patient has an obvious head trauma and they're taking anticoagulant medications such as Coumadin or some of the newer anticoagulant medications on the market, they're at high risk. Obviously, anybody intoxicated in the EMS environment who tries to refuse care is high risk. Abnormal vital signs, tachycardia, hypotension, that should raise your suspicion there could be something else going on. Treat or resolve narcotic overdose. You have a patient that's in near respiratory arrest, you give them naloxone and they want to refuse. They may have the capacity and the competence and have an informed refusal to allow them to refuse care, but again, might be important to talk with the online medical control. And then any of our high-risk mechanism injuries, pretty much linked to the spinal clearance protocol of those patients, but if they're unrestrained, ejected, any of those high-risk mechanisms we talk about, they're at a higher risk. If anybody who might be suicidal, obviously, and then again, our apparent life-threatening event patients we talked about earlier.
Response to, you want
Go
to
ahead. No.
I say the response to domestic violence, there were no changes. The only thing we did do was the old document had probably a good half a page or more of references. And we have those references if you want them, but just to kind of clean up the protocol, we took them out. If you need them, just give me a call and I'll send them to you.
Special resuscitation situations and exceptions. Just a few changes. After meeting with the medical examiner's office, we were able to clarify a couple issues. Number one, in the setting of a sudden unexplained infant death, they asked us if at all possible to obtain a carbon monoxide level in the room where the infant was found. And one other issue that has come up is what to do with a hospice patient who has died and 911 has been contacted. What we discovered through our meetings with the medical examiner's office was that in the setting of a patient with an expected death, such as a hospice patient, these are not considered to be medical examiner type cases. They do not need to be involved in these cases. So if what you were called to the scene to do was to help move the patient, if they had fallen during the process of their death, if they'd fallen, if they've slipped out of bed, something like that, and you were called to help assist them back into bed, by all means you can do that and not feel like you are violating any New Hampshire law.
And just to kind of add a couple other things with this protocol, we did kind of simplify the factors of death, particularly for trauma. So we had a lot of specific injuries listed before, but basically if there's a major blunt or penetrating trauma, those patients can be terminated in the field or not attempted to have resuscitation on some of them. Their chance of survival is very, very low if they have had those injuries or in cardiac arrest from it. And just a reminder to EMS providers, resuscitating patients in the field is really ideal. We do not need to transport every patient of a cardiac arrest. There are obviously situations where we need to do that, and we're also sensitive to the fact that a lot of our EMS providers may not have the training or the skill set at this time to talk with family members about ceasing efforts of resuscitation. But by all means, it's really expected to treat these patients in the field, and basically you're going to work the patient to the criteria of when to stop in this protocol until the decision to basically transport or terminate resuscitation efforts in the field is recommended.
Well, the last one in the policy sections is a new one. It's the trauma triage and transport decision. This comes directly from the CDC guidelines as well as our New Hampshire trauma guidelines. So, not sure.
We spoke in the very beginning in routine patient care about using Glasgow Coma Scale. The first question in the trauma triage transport decision is, what's the patient's Glasgow Coma Scale? If less than 9, they might meet criteria to be transported to a level 1 or level 2 trauma center. And then it starts off with physiologic criteria: blood pressure less than 90, respiratory rate less than 10 or greater than 29, need for ventilatory support. Then it goes down into the anatomy of the injury, penetrating injuries to the head, neck, torso, and extremities, chest wall instability, 2 or more proximal long bone fractures. All those criteria are the same. We just sort of reorganized this differently and made it so that it correlates well with the CDC's recommendations. So this process will be mirrored nationwide.
Yeah, and one of the things to remember, I think a lot of us have learned in the past about mechanisms of injury, such as fall, greater than 20 feet. Sorry, A fall greater than 20 feet for an adult, or high-risk auto crashes, ejection, et cetera, as being a criteria for activating the trauma system and going to a level 1 or 2 facility. It's really more based on physiologic criteria, like Tom had mentioned, in terms of your vital signs, your GCS, and your anatomy of injury, of what injuries you find. The mechanism is still very, very important, but if you only have a mechanism and everything else looks okay, you still may request a trauma team alert at the facility you're transporting to, but the patient doesn't necessarily have to go directly to a level 1 or level 2 trauma center.
Okay.
All right. So that completes the policy section, and then the last section is the mass casualty, and we've got hazardous material exposure. There were no changes to this section at all. So we had the hazmat, we had the mass casualty triage, and then the radiation injuries. But like I said, there's no changes.
And sort of at the end of the protocols, you will find some new additions that Vicki did a fabulous job in creating. An adult formulary with medications, dosages, intervals of using them, etc. There's a pediatric drug list as well. Scope of practice, and an example of the pulsed form.
Right.
So, again, I think the protocols this year are vastly improved over the previous editions. Thanks to Dr. Swosey. Good job. We appreciate it. And I hope you guys all like them as much as we do.